Good evening, everybody, and welcome to the Royal Society of Medicine. Very excited we are at the Royal Society of Medicine now because we just heard last week that King Charles has agreed to be our patron, so that is good news for us. And it's lovely to have you all here with us in this, my favourite lecture theatre, this place. We're going to hear tonight the third Howard lecture. The first one was on diabetes, Stephen O'Reilly from Cambridge. Then we had Mark Emberton talking about prostate disease, a condition close to my heart, well, close to my prostate, I suppose, you could say. So this is the third one, and I'll be telling you a little bit about John Nolan. John reminded me that on his slides he will have access to the actual papers he's talking about. He told me that he's written 117 papers. I'm going to check you up on that when I get out of here, John. So when this will be recorded, it will be on the website. So if you want to check that he's telling us the truth and reporting for what is from what he's published in his papers, that facility will be open to you. Well, I knew Alan Howard for at least 25 years. And he was an incredible character. He was the inventor, of course, of the Cambridge diet, which was the very first low-calorie diet. 350 calories a day were all you're allowed to have, a liquid diet, so you couldn't have your croissant for breakfast and your bacon and eggs to follow. All you could have is the liquid diet, but it worked incredibly well, and of course it became famous in not just in the UK, but in North America and indeed all over the world. He became very famous on the back of that, and he was a great character. He supported me as president of the Cambridge Medical Graduates Club, but more importantly, he supported Downing College, and he subsidised and helped to build 3 beautiful buildings, one of which was the gorgeous theatre, which they used for lectures, but also for performing arts as well. So he was an incredible character, and his daughter Julie and his son John in the front row here have carried on the tradition. And tonight, I think it's particularly appropriate that we are discussing nutrition, because that was John's life work, really. And nutrition and its impact on 2 enormous problems, growing problems, macular degeneration and dementia. And maybe if we change our diets, maybe we can stave off these things, maybe we can get some improvement. We'll be hearing from John about that. Certainly we're eating all the wrong foods at the moment, so perhaps avoiding some things, just as well as taking the supplements John will be telling us about, could be equally important. So John is going to talk for exactly 40 minutes. I've told him we do have a guillotine here which comes down and severs the body of the speaker exactly in half if he talks for too long. And then we're having a panel discussion of a neurologist, a nutritionist and a geriatrician, that's the word. And John will be on the stage as well. So we'd like some questions from the audience. If you are asking questions, if you just wait for the microphone so that everybody can hear the question you have. So store up some questions in your mind. John, we're looking forward to your talk, and you're on. Thank you very much. A round of applause.
Thank you very much, Roger. I'm a good dancer, so I might be able to avoid the guillotine. I will do my best to stick to 40 minutes. Firstly, it's a great honour. Thank you to Julie, the chair of the Howard Foundation, and Roger as the Royal Society of Medicine for this wonderful opportunity, and to all the other members of the foundation. I appreciate you and thank you for enabling me to do this. Before I officially start and before my clock starts, I actually want you to sit back and listen for 1 second, because for me, this is the reason why we're all here. That's if it works, of course. No, it didn't work. There's a bad start. Hold on. Reese. It won't allow me click this. Hold on. Can we get... Well, you know what? We'll move on. Maybe I'll get to play it at the end. But what that was was a voice recording that I received on my phone from a patient only 2 weeks ago. And this was an elderly lady who presented at first hand the issue related to having macular degeneration. And it allowed me to reflect on the impact of that condition on that lady and her quality of life. So the point is, regardless of science, regardless of medicine, regardless of what we do in our working lives, when we're working with age-related conditions like macular degeneration and like Alzheimer's disease, I think we have to remember the patient centrally, and that we have to think about the patient and their story. And maybe I'll get to play that for you in a bit. So, okay, we're moving on. It's now not moving. There we go. Sorry about that. It's warming up. It's warming up. Okay, so we'll officially start the time now. So my duty tonight is to connect with you over 20 years of research that has been done, not just in Waterford, Ireland, but from across the globe, from that of my research friends and research colleagues. And we've all been on one mission. And our mission has been to try and work and identify ways that we can use nutrition to enhance human beings' quality of life. And our particular interest at the beginning was related to vision, visual function, and a disease called age-related macular degeneration. So I'm going to tell you that story as we progress tonight. But what we didn't know back then at the beginning was how this was remarkably connected to what's happening up here in the brain. So what I want to achieve is I want this to be educational from evidence-based science. I want you to be interested. Hopefully, if I do a good job, you'll be interested. But the most important piece for me now is that I can give you information, if you're a doctor, that allows you to think differently and change what you do in clinic tomorrow. As a patient, to understand, if there's people from the general public here tonight, what this research has delivered and what it can do to support you and your quality of life. Okay, this is unfortunate. It's not. Okay, there you go. I'll have to stand closer maybe. So the first few slides, what I want to do is remind you, I'm not going to labor too long on this, but I'm going to show you some data, and these are numbers, but it's going to show you the extent of the problem that we're dealing with. And I focused on the United Kingdom. In 2020, the prevalence of AMD was estimated to be 1.3 million. And this is data from the Royal College of Ophthalmologists. Oh, this is really not changing. Okay, I'll have to. AMD itself, the cost of that is 2.6 billion per year. When we look at dementia, we're looking at almost 1 million people. And what we see is that there's 209,000 cases per year. And every 3 seconds, someone in this world develops a form of dementia. Every 3 seconds. So this is a growing problem. It's a problem that it's not going away. And it's not going away because we have a growing population and we have an aging population. So it's remarkably challenging and remarkably difficult. And it's not just challenging for society and the sufferer. It's remarking, as we've seen from the data, the cost of this, the economic burden to healthcare systems. We know because of the growing population and because of the aging population, by 2040, the number of people, basically all those statistics, are going to double. Already our health systems are overwhelmed. Already those of you in the audience that are working with patients on a daily basis, you know you are overwhelmed with this. Dementia itself, look at the striking figure we see here. 34.7 billion per year. And this is significantly greater than macular degeneration because when you look at the breakdown, it's not just caring for the patient, it's the cost to the family members. For every one patient with dementia, there's 3 or 4 family members that are greatly and grossly affected. And this is just a massive cost. So this is the first slide that I want to connect AMD and Alzheimer's disease. in a thought process. And what I mean by that is, our whole area of research was, is there something we can do to get in front of these diseases? I'm going to speak tonight about standard of care and what happens in medical ophthalmology and what happens in Alzheimer's disease. But to understand the etiopathogenesis of both of these conditions, why do we develop them? One thing that we do in epidemiological science is look at the risk factors. And now there's many, many risk factors for both of these conditions. We call these putative, suggestive risk factors. But there's one commonality, and these are related to what I call the established risk factors. And you can see these established risk factors here. Age, family history, genetics, one of the same thing, but they're sometimes coded differently. Cigarette smoking and nutrition. So the point is, without doubt, these risk factors have a direct link to these diseases, age-related macular degeneration and Alzheimer's disease. And already we see an overlap. But what I'm interested in is, within those risk factors, what's modifiable? What can we change? We can't change our age. We can't change our current genetics. We can impact on our future genetics. So really focusing on these positive modifiable risk factors like smoking cessation and nutrition is what's going to be key. And that takes us lovely and nicely into environmental risk factors. And this is really now when we start to think about nutrition and wellness around this. And this is where we think about basics around light exposure, particularly when we're talking about macular degeneration. But we must understand with light that we're not talking about ultraviolet light, and I'll speak to that tonight. We're talking about visible lights. We must see and understand that in this new world that we all live in, where we have all of these devices and all of these lights shining on us for much longer, the blue light hazard ratio tells us that we have many, many more challenges than we did 50 or 100 years ago to contend with. And this is important for any of the optometrists in the room who specialise and work primarily in optics. But what does optometry do? It focuses on the front of the eye primarily. But now, thankfully, that's changing. We're starting to think about optometry role in healthcare, optometrist role in the retina. But I'm going to talk to you tonight about the optometrist's role in filtration at the back of the eye. And that's crucially important, because all of this starts and all of this happens because the initiation here is something that I call photooxidative stress. Photooxidative stress, what is it? When cells are alive, we celebrate that they're working hard. The cost of doing business with that is a production of a molecule called a free radical, which is unstable and reactive. And here you see a picture of the eye, and at the back here, we see this is the retina, we see the macula. And the magic happens right there at the macula. And I'm going to show you a different image in a minute where we will understand that that 4% of the retina mediates over 90% of our visual experience. So logically, to me, if I want to use environment, lifestyle, nutrition, is there a way I can optimize protection at that sensitive, specialized tissue? That's really, really important. And again, I make the point here that the light that gets to the back of the eye is the visible light spectrum, the colors of the rainbow. So you must think of the electromagnetic radiation spectrum. Shorter wavelength, high energy. High energy is very, very damaging. But the front of our eye, our cornea and our lens, filters out that ultraviolet light. And that's why with cataract surgeons that are in the room, you'll put in, as standard, a UV filter, right? But the retina must contend with the visible light spectrum. And what I was fascinated to learn in the early days is that we have no blue photoreceptor cone. So when we look at the visible light spectrum, we have this short wavelength blue light that's basically a problem because we can't receive that light. And not only will that cause photooxidative stress and photooxidative damage, that will cause visual confusion. And what I'm saying to everyone in this audience, if I was somehow, some way, to optimize nutritional filtration right there at the macula, I could, in theory at least, give you a better vision, a better visual experience today. And my vision, for vision, is that we will not just think about diseases and trying to fix them. We will think about how we can use nutrition of the eye and the brain, as you'll see, to enhance function today. And you're going to learn about how we filter these short wavelength lights. The goal is, and this is not drawn to scale or correct, but it's just to make the point that what looks like a spaceship is the back of your eye. That's a fundus image, and we see the picture of the back of the eye. And right here, you see the macula. And this is the 4% of the retina that gives us most of our vision. And this is what we really want to keep healthy throughout our lives. And this is what gets sick when a patient develops age-related macular degeneration. This is the tissue that becomes unwell, if you like. And it becomes unwell because of photooxidative stress. That's the initiator. When an eye doctor in optometry or ophthalmology looks into the back of the eye, here we see drusen, pigmentary changes. These are changes that are normal, if you want to call them normal, because they happen with normal aging. But they're not normal because we don't want them there. So how can we stop them? How can we stop these age-related changes at the back of the eye? Moving further on, you see late AMD. That's an example of what we will refer to as wet AMD, or neovascularization, which is basically that eye is so sick, blood vessels are growing and overgrown to try and fix itself. This is an inflammatory response to the oxidative stress. The initiation is the cost of doing business with life, oxidative stress causing this to happen in the first place. Now, I was interested, and I forced myself to read some of these documents, the Royal College of Ophthalmologists, and this is the guidance recommendations for age-related macular degeneration here in the UK. And what it says is, do not refer to secondary care when the diagnosis is confirmed as early AMD. So in other words, that first image where I showed you all those changes, the current position of eye care is to watch it. And we wait until we get to the end game, where we have total atrophy at the back of the eye, to start using anti-VEGF therapy. So the standard of care is anti-VEGF injections. For those of you that don't know what they are, they're basically molecules that you inject through the front of the eye, that go to the back of the eye, that clean up the unwanted blood vessels, and they have a very positive effect at that time. But the point is, the cost of that is multiple and multiple and multiple injections forever for that patient. In the back end, the disease is still there, it's still present. I put up a study from the Republic of Ireland. This is the Irish Longitudinal Study of Aging. The principal investigator, Professor Roseanne Kenny. I was working on the ophthalmology part of this. And long story short, we sampled randomly 5,000 people from the Irish population. And this was wonderful, because in this wonderful sample, we were able to calculate with accuracy, by imaging, taking photographs of the back of the eye, we were able to quantify the number of people and give a true prevalence data for macular degeneration. The point is, of the 86,000 people in Ireland that have some form of macular degeneration, current standard of care treats just 0.3% of those. We wait for everyone else to get there. This is the publication. And as Roger pointed out, this is a QR code which will allow you, we'll make this available after the lecture, so you'll be able to get all of these publications. So moving on, I would suggest that prevention should start here. Oh, now it's working again. Or maybe it even should start here. Maybe prevention and eye care and commitment to optimization of protection at the back of the eye should happen when things are good. And that is my vision for vision, and that is what I believe is Health 3.0, which I'll come to in a minute. And we can draw similar analogies to Alzheimer's disease. Again, a truly terrible disease. And again, how overwhelmed the medical systems are trying to deal with this. We're aware of that. We've seen a lot of excitement in the media recently about new drugs and new diagnostics, and all of which are important. But I think we'll have to acknowledge that while these are developments, they're not without significant challenges in terms of the feasibility, the cost of getting access to these drugs, side effects that are connected to those. And we may discuss this in more detail when we move in to our panel discussion. But ultimately what I want and my vision is that it starts with you. It starts with the patient. It starts with the eye care professional, and that we don't wait until the problem is too bad. So prevention and Health 3.0, as I call it, is something that we must look to if we are to positively impact on these diseases that are so difficult. Moving again back to this document from the Royal College of Ophthalmologists and considering their position on environment, lifestyle, nutrition, I'll show you what's happened here. The conclusion here is that nutrition and supplements, a healthy diet rich in fresh vegetables, eggs and oily fish is recommended. ARIDS 2, which I'll speak about later. ARIDS 2 is this big study that was conducted in the United States of America, a longitudinal study following patients now over 10 years where they did a nutritional intervention. And they actually conclude here that they do not recommend the use of that multivitamin. They actually make that recommendation. Now, there are other questions, challenges and issues that I have with that particular formulation, which I'll speak to later. But it did identify and confirm from a morphology being disease. Does the disease get worse or better if you use these interventions? It was a very helpful and well-conducted study in that regard. But I'm going to show you soon that the science has absolutely moved on. So in a world where nutrition devolves, and I want this to be one of the learnings, you may expect me as a nutritional scientist to stand here and tell you that we can fix everything with nutrition. We can't. No chance. And the reason why we can't is the micronutrients that I'm going to speak about tonight, which are known as carotenoids, grow in plants to help plants grow in difficult environments. But as we farm and as we overfarm and as we overproduce and as we use pesticides and as we make it easier for these plants to grow, we are producing plants that are devolving in their micronutrient concentration. Less and less and less and less. And I'm going to show you some data on that in a minute. But the good news is our knowledge and our data in terms of the macular pigments and nutrition of the eye and brain has continued to evolve and expand. And this is where the opportunity rests, and this is what I'm really going to show you tonight. So my primary area of research is related to carotenoids. Carotenoids, what are they? They're plant-based pigments found in nature. They're beautiful. They give the world the wonderful colors that we see. There's about 700 of them in nature. When you look at birds' feathers, when you look at fish skin, when you look at peppers, when you look at egg yolk, all these wonderful foods that have these natural colours there because of carotenoids. There's about 50 in our diet, but remember what I said about nutritional devolution. We're consuming about 1.5 milligrams. That's about 20 times away from the amount we need. So if I was to get the healthiest person in this room, I'd firstly congratulate you. I'd ask you to continue, but I'd also measure you and I'd tell you and I'd show you that you're still miles away from having enough of these particular carotenoids. Our blood system delivers and transports about 20 of these carotenoids when you include the isomers. And our initial work with David on HPLC allowed us quantify the carotenoids that I'm very interested in, and they are the carotenoids lutein, zeaxanthin, and mesozeaxanthin. There's 3 carotenoids which are found in the eye. And these same carotenoids, and now we're connecting the eye and the brain again, are also in the brain. So the macular pigments of the eye, you probably won't remember these names: lutein, zeaxanthin, and mesozeaxanthin. I'll show you their chemical structure in a little bit, and I'll explain where they come from. This is a marigold flower. In Mexico, they call it cempasúchil, which is a beautiful flower. They're grown in the fields in Puebla, Mexico, and they're left to their own devices. And it is from these petals that we are able to source and get access to high-quality amounts of the carotenoids, lutein, zeaxanthin, and mesozeaxanthin. And we also know from our recent work, which began in animal models, that these same carotenoids get to the brain. And now I'm telling you that the retina is the window to the brain. So imagine if I can measure carotenoids in the eye, and that's telling me what's going on up here. And the answer is, it does, and we can. So that's wonderful. The devolution point again, because I could see heads moving when I spoke about this. 1953, 1 bowl of spinach is equivalent to 43 bowls in 2020 from a total nutritional value, because this represents the challenge that we're faced with. The supplement used in the ARID study, which I referred to, it had high amounts of zinc, which we wouldn't be allowed to use here. And therefore we didn't in our trials. But in addition, this supplement formula, had only 2 of the 3 carotenoids, lutein and zeaxanthin. And our early work showed us that it was missing what I believe, and what we've now shown to be the case, the most central and the most important carotenoid, which is a carotenoid called mesozeaxanthin. So if you think of macular pigment as a protective mountain, a protective triangle like we see here, without the mesozeaxanthin, you're missing the full picture. And when we look at to the back of the eye in terms of how we can image and see this, here we see at the very center of the macula, that peak of the mountain, that protective pigment which comes from those plants, is mesozeaxanthin. Lutein is further out, and we know this from anatomy studies where we actually dissect and work with maculas to quantify the carotenoids that are specifically there. So these type of measurements was the initiation to tell us that mesozeaxanthin is crucially important. It was our job then as scientists to go really and verify and test that. And here you can see this is the biochemical structure. It's C40H56O2, which basically means there's a hell of a lot of hydrogens there, which is going to allow it to be a very good antioxidant. And carotenoids are wonderful antioxidants because when they provide the electron to the radical that's missing an electron, it doesn't itself become unstable. So there's not this negative cassative reaction that takes place. It's a very natural process. It's like sunscreen inside the eye, for basic description. And remember I said already we've no blue photoreceptor cones, but the reason why the carotenoids are crucially beneficial and important there is because they filter at 460 nanometers. So in other words, that short wavelength blue light that is highly problematic because it's causing photooxidative stress, and that is highly problematic because it's causing visual confusion, light scattering, lower the contrast sensitivity, issues with nighttime driving, all of these issues that we see with age-related conditions like macular degeneration. These natural filters, which are carotenoids, are ideally located at the macula and have the absolute ideal antioxidant and optical properties to provide a really good protection at that special tissue. And here you can see this is a blue, you can see the dark area here. This is a blue laser, and it's basically dark because of the filtration of the macular pigment. So what would normally happen if the pigments weren't there is the lipofuscin would be excited and you'd see all equal colours, but we don't see that because of this filtration. I've made the point about the antioxidants, and the mesozeaxanthin is the most powerful antioxidant, but the combination of mesozeaxanthin, lutein and zeaxanthin, in biology we call this a biological synergy, gives the most potent and most superior antioxidant benefit to the macula possible. And that is why we've evolved as humans to accumulate pigment from the cradle. From the second we're fed, the first food we get are fat-soluble carotenoids as part of colostrum. So straight away, nature wants us to accumulate these pigments to deliver this. So the whole point of this is that it's a fine balance. We want the cells to be active, we want to be alive, we want to use normal nutrition to give us enough protection. But really, we have a massive problem and challenge on our hand because of how long we're all living. Think about that for a second, how long we're all living. And we should celebrate that. But I'll only celebrate it if we can keep our function. And if we can keep the function of our loved ones as we celebrate this aging and growing population. And the point is, in the general population, we know now with certainty that, as I made the point already, the healthiest person in this audience, I can still improve your pigment with appropriate supplementation. And that's unique. So now let me provide the evidence. That's the background to everything, that we have these pigments that are naturally sourced, ideally from food, but from supplements we can get them from marigolds. So we've been testing this for over 20 years. we did an audit of our own publications, and we've measured carotenoids related to specific outcome measures, maybe vision, maybe cognitive function, maybe blood response, but some kind of response in 41,892. And I put this up here because when we publish our papers, which are designed and powered and conducted to look at function, in medicine, when it's not 5,000 people over 20 years, we don't take it serious. And we need to change that. We need in medicine to use the totality of the evidence that's available to make positive changes to help our patients. I truly believe that. This was born out of 65 clinical trials where we developed specialised testing and outcome measures related to vision and cognitive functions. And we did this in this beautiful facility. And again, to acknowledge the Howard Foundation for their support of Carriganore House, some of the laboratories within. We have the Howard Laboratory there, but this is the headquarters in Ireland. And within this facility, every day, there's 20 people working with carotenoids, with nutrition, with vision, with patients, everything from young, healthy patients all the way through to patients with Alzheimer's disease. And we run human clinical trials. We assess diet. We measure visual performance. We look at the retina. We image the retina and we measure macular pigments. This is a technology from Heidelberg Engineering, and wonderful technology that allows us to get very accurate measurements of not just looking at the diseases, but also being able to quantify the macular pigments. We're able to measure cognitive function, reaction time, attention, memory. All these measures related to what the brain is doing for us. In the laboratory, we're able to quantify. I can take your blood sample and I can extract out the carotenoids, and I can measure on what's called a high-performance liquid chromatography system the amount of carotenoids present in your blood. And therefore, if I change your nutrition or if I provide a supplement, I can measure how effective that is by changing your taxi system, your delivery system amount of carotenoids. In terms of a call to action, one of the things that I want to do is identify the challenges of how all this research can and should be translated, but also acknowledge that we can now do things in the clinic setting, in the ophthalmology clinic, in the geriatrician clinic, in terms of working with patients that are specifically and sensitive to measuring carotenoids. So I'll show you that. So the whole journey began in 2005, my own PhD, which was published in 2005. And I put this up as a reflection piece, but also to show you that from the first paper published in my PhD, even back then, when we looked at the risk factors, what we did in that experiment was we took 1,000 people from the population who were free of disease, no AMD, and we measured their risk factors, age, family history, genetics, nutrition. We put it all together. And long story short, what we saw was that the individuals at the highest risk of age-related macular degeneration had the lowest pigment. So this was the first time that we closed the loop between risk factors for the disease and these nutritional pigments which we were able to measure. And as you can see, the conclusion from my whole dissertation was that the importance of this finding rests on the fact that any protective effect of macular pigment depends on its ability to defend against chronic and cumulative retinal oxidative damage, whether induced by blue light or as a result of high oxygen metabolism. But importantly, this will need to be exerted in the young to middle age. So exactly what I'm just saying to you. Back in 2005, we said the exact same thing. So very important time here was as I finished my PhD and started to go to, I think I met someone that was at the ARVO conference here already. One of the major conferences we used to go to is in ARVO. And this is where I got to meet the great Dr. Alan Howard, who sadly is no longer with us. But Dr. Howard has built and left a legacy within our research field, within our research community, and for me personally. And he did so because, as we heard already, his own work on the Cambridge diet. But Dr. Howard, as a scientist and as a true scientist, wanted to empower individuals. David's here in the room. I know he's benefited from Dr. Howard's support, as have I, in terms of he wanted to empower us to be able to do research and not to be looking over our shoulder for the next grant. He wanted us to be able to do research and bring new researchers to the table. So we acknowledge and we compliment Dr. Howard for that. So he's provided great support for clinical trials, individual support for career development, and something I'll speak to you about later called the Brain and Ocular Nutrition Conference, which has now been well established. So I met Dr. Howard at the ARVO conference, and we discussed the research that I'd been conducting and his interest, and we put it together and decided to really test this mesozeaxanthin story, this central macular carotenoid that I've been speaking to you about. So we did that, and we ran the MOST trials, the mesozeaxanthin ocular supplementation trials. And like any good science, we wanted to evolve our ideas and our abilities. So we conducted exploratory trials. They were, in the beginning, small sample sizes. But it allowed us to develop protocols and ideas while confirming the following: the wonderful response of these carotenoids, their safety, which is crucially important to medicine. First, do no harm. You cannot hurt people when you're working with those eye carotenoids, lutein, zeaxanthin, and mesozeaxanthin. They're totally safe. A discovery about a central dip rebuilding, which I'll show you in a minute. And actually, the most important thing, what this means for our patients. Who cares? When we enhance macular pigment, are we changing anything in the eye relates to vision? Are we changing anything up here in terms of cognitive function? So I'm turning the research question upside down. I'm not just looking for disease. Fixing, getting rid of plaques in the brain or even drusen in the eye is great, but does it change the person's abilities and qualities and function? And that was where our research was conducted differently. We powered and we designed our projects to look at those type of outcome measures. Another major part of the discovery was not me in a marigold field, it was the marigolds themselves. And the Sempasucha provided the unique formula. This is from Industrial Organica. And this is unique, and it is part of the discovery because of the quality of this particular formulation and the stability of it. So when we look at food supplements, and we look at the multiples that are out there in terms of food supplements and the claims and the false claims that are around them, I say two things. If you as a doctor are making a recommendation, make sure that there's a clinical evidence base connected specifically to that formulation. You owe that to your patient to be aware of that and not be casual about it. And make sure that it has a stability program that validates its stability over its shelf life. And this product from Industrial Organica was exactly that, our Mexican colleagues. And here you can see this is just the chromatography, which is basically the DNA picture, if you like, of what's in the formula. And this was almost at 100% purity, meaning there's nothing else in that formula, only the three parts of the jigsaw that we wanted to work with. So we had a fair chance of changing these carotenoids because they were there and because there wasn't other carotenoids competing with them. And this is important because if you don't do that, we've seen products produced poorly, low quality. You'll see here they degrade extremely quickly. And again, I say the patient deserves better than this. So please be aware of the work that's been done in particular formulas and not just in a generic way. Moving on, the central dip discovery was that, remember I said macular pigment was shaped like a mountain. This was a PhD student of mine, Mark Kirby's. And what we showed in this experiment was that in the population, there was about 12% of the health. So this room, 12% of you who don't have AMD have a volcano in your pigment. You don't have that protective mountain. And we hypothesized at this stage that you were lacking mesozeaxanthin, because remember, we knew from the anatomy studies that meso was central. So we wanted to test this theory, and we ran an experiment to do the supplements. And what we could see was when we used high lutein, which was 22 milligrams of lutein, remember the average Western diet is about 1.5 milligrams of carotenoids combined, we couldn't fix the problem. But when you look at the 10-10-2 formula, so this is the formula that's now commercialized as Macu Prime here in Europe. This unique 10-10-2 formula is what rebuilds the central pigment. So this was a major discovery. In other words, if we were to use the AREDS intervention, the patients would leave the experiment with the problem. We couldn't fix the dip. But simply by providing them the mesozeaxanthin, we were able to fix that central dip and rebuild it. So putting all of this together, we then were ready for the big trial, which was the CREST trial. We had the protocol ready. We had the formula that we wanted to use. the MacuHealth MacuPrime formula, and we knew the outcome measures that we wanted to work with. So I competed and I won a European Research Council CREST grant initially at 1.5 million, which grew to 2 million over the 5-year grant project. And that really allowed me build to and onto the team in terms of our capacity of scientific caliber, but also in the technologies that we were able to use. There was 2 parts to this experiment. The first one was a combination of lutein, mesozeaxanthin, and zeaxanthin compared to a placebo in a normal population. I mean normal in the context of no retinal disease following screening. It was 105 healthy participants, but they all had one thing in common. They had low macular pigments in their eye to begin with. Okay? So the research question was, could we increase the macular pigments and could we improve their vision? We only did one thing. We gave them the supplement. The question was, could I give everyone in this audience a better vision just by giving you the MacuPrime supplement? And here's what we found. We measured the pigment using the Heidelberg Spectralis. We can see here again the blue. And when you do a green image, you get that lower color. So you can digitally subtract one from the other because green is not absorbed by the yellow macular pigment. And now we can measure the full pigment. And what we found in these patients, or the healthy population, was the placebo stayed pretty much the same, but the active had 100% response and success. So everyone was getting a benefit. When we looked at vision, and we looked at contrast sensitivity, and I want to point this out. In classic eye care, optometry and ophthalmology, the international language of vision is acuity, 20/20 vision. Black letters on a white background. Black letters on a white background, while important to vision and our understanding of it, are missing the big picture about how your patient feels about their vision. So, with this knowledge and the knowledge that contrast sensitivity itself, and we know this from Osley and Sloan's work, contrast sensitivity itself correlates with how we feel about our vision. So if you have a patient who's just had cataract surgery and you're measuring acuities, yeah, you'll see the benefits and it'll correlate, but it won't correlate anywhere as well as if you were to measure contrast sensitivity. Equally, if you look at a disease like macular degeneration and you measure visual function and you look at contrast sensitivity, the first measure to fall and deteriorate as the disease progresses is contrast sensitivity. So in other words, what I'm saying loud and clear here is that there are measures of vision that we have access to that are easy to do and that are not being implemented routinely, or at all, in fact, in the clinic setting. And it's something I want to see change, and it's something I'd like to see eye care to consider, because we've seen in our trials that this is truly and wonderfully important. This is the change in contrast sensitivity for the placebo. You don't see one over 12 months, but here is the active group. About 15% improvement in visual function when you look at contrast sensitivity. It's 6 cycles per degree. It's just a wonderful thing to do, and it gave us our primary outcome measure in the CREST study. So that's CREST normal. Moving on to CREST AMD, which was basically a head-to-head trial. This was the MacuPrime Plus compared to an AREDS-like formula. So basically a supplement that had 2 parts of that triangle versus the MacuPrime, which has all 3, plus the co-nutrients that were used in AREDS. This was a double-blind head-to-head trial, 121 patients. And what we saw was that the AREDS intervention did well. We had some non-responders, but when we used the triple carotenoids, we can see here the clinically meaningful improvements were far greater and statistically so in that population group. So again, validating our idea, validating our discovery around the importance of mesozeaxanthin, we have a clear benefit here. You can see here as well in our HPLC really able to take it from almost a 0 level up to something that's pretty high. So the supplement is working very, very well indeed. Now, moving on to the last part of the information. How am I doing for time?
Yeah, got another 7 minutes.
7 minutes. Okay, I'm going to get there. Perfect. I'll avoid that guillotine. Right. So very quickly, but most importantly, we know that in the brain, not only are carotenoids present, we know vitamin E, we know that the omega-3 fatty acids that I'll speak to are there. One major study done in the US, Professor Liz Johnson, she worked with centenarians. And what Professor Johnson did was she had measured these wonderful patients' macular pigment. But then these brains were donated and provided. And Professor Johnson and her team were able to quantify the carotenoids in the brain. And what she discovered was that actually the measurements in the living person of the carotenoids, which she did, of course they were alive, to what we were able to quantify in the brain were highly correlated. So again, and in other words, and for demonstration, if I was to measure everyone in this room's macular pigment, which we can do, those of you with the highest score will have the highest amount of carotenoids in the brain. Remember what they're doing. They're antioxidants. We'll come to anti-inflammatory in a second. Quickly, I need to say DHA in the brain is crucially important, not just from a structural role in that the brain is pretty much mostly fat. Okay, 60% of the brain is fat, and the important fats there are these omega-3 fatty acids, which we classically get from fish. The DHA part of that is really, really important. I would say that we should recommend fish and fish-like foods, and we do, but again, we're just not getting enough from normal diet. The TILDA study, going back to this Irish study with the 5,000 people, showed us that, again, the people with the highest macular pigments when they were alive, when we also measured their cognitive abilities, attention, memory, reaction time, strikingly were correlated. So again, use this room as an example. Those of you in this room with the highest pigment scores will have the best attention, the best cognitive abilities, the best memory, and so on. And this was what we call an observational study. So Professor Mulcahy, who's with me, we started at that time to work together, and working with Professor Mulcahy, we spent a long time going through ethics. We conducted these experiments. And these were from the TILDA study, these were showing that correlation. But our own work showed for the first time ever that patients with Alzheimer's disease were highly deficient in macular carotenoids. And their vision were on the floor. And then obviously we may think that, are they just not eating it? But what we wanted to do then was supplement, and I'm moving through this now, and we did a series of interventional trials. When we used MacuPrime on its own, we could change the carotenoids, but we had no effect on their cognitive abilities. When we added MacuPrime to the omega-3s, which is now available as Remind, we could see a wonderful response in the blood, and also working with the carers and looking at the reports coming from clinic, we could see great improvements. And this led us to the last trial, the Remind trial, because just like we've done in Vision, all our work over 10 years on cognitive function and cognitive abilities informed us as to the type of formulation that we needed to use and what we should be measuring. So working with Professor Mulcahy and within our clinic and working with all her colleague doctors to identify patients who were on the journey of Alzheimer's, who had it established but were progressing. These were the patients that we wanted to work with Remind, and this was the last trial. And we did a double-blind placebo-controlled trial, which we finished remarkably during the pandemic. We didn't get to recruit as many patients as we had originally planned. After 12 months, the results were really, really impressive. The placebo was flat. The change in lutein, this was one of the carotenoids that I'm showing you, was remarkably high, that you can see here. Moving on to the last few slides. The change that we saw in skin was correlated with that. But also, and importantly, taking the data from the whole patient story, we call this the clinical collateral, as you know. When we look at the active group, we even saw patients that demonstrated an improvement based on the care reports. And mood is something that's very important and significant in Alzheimer's disease. A success would be to keep everyone unchanged, to keep them stable. But what you see in the placebo is everything moves to the right. Looking at memory, you can see the same thing here. And here you can see the change. Improvements in active, yellow is active. Unchanged, significant in the active, but you can see how many people decline. So this progressive journey of Alzheimer's disease in the placebo group was clear to be seen, but we are holding patients and maintaining it there. And this was published in the Journal of Alzheimer's Disease. And again, we'll make all of these papers available. So the last point, where do we go from here? I believe that drawing from our work on skin carotenoid measurements and serum carotenoid measurements, we should be looking at Can we measure skin scores in a way that correlate with serum? And the good news is that it absolutely does. We've been able to validate our skin measurements to this HPLC data. And this is wonderful because it's non-invasive, it's quick, and it's been used now successfully across Europe and in the United States, where doctors are using this to help their patients. Here's just data from a clinic in Ireland showing a remarkable response in just 6 months. So the point is we have indicators now that are correlative of what's happening up here and correlative of what's happening up here, and based on Remind and everything else, we know. So the final piece is the opportunity is Health 3.0, retaining function as we age. I like the expression from the cradle to the dance floor. As I said, these nutrients are provided from the very beginning. I never thought that we would have evolved in our knowledge this way, that we could have an impact not just on the eye, but also on the brain. And importantly, around the functions, the cognitive functions, the brain functions, and the visual functions. These are all encompassed, these are all related, and we truly have connected the eye to the brain and our knowledge of nutrition. So it is your opportunity. It is your opportunity if you're a patient. It is your opportunity if you're a clinician. And what we need to do is shorten the time it takes to translate all of this science into clinical application. Particularly as we see with Alzheimer's disease, where we recommend that has to be used in the co-management. We're not saying that any of these nutrients should be replaced for medical treatment. They should be used in collaboration with. Very last slide, I promise, in terms of study. I don't have time to go into this, but we have a new paper just accepted on inflammation. So today I focused on oxidative stress and the importance of this sunscreen effect, if you like. This new data has shown us actually when we look at classic measures of inflammation, TNF-alpha, IL-1 beta, and even go downstream from that, when we get sick systemically, when patients have high inflammatory status, this data shows us that these carotenoids working systemically can reduce oxidative LDL. This has a massive implication for the future in terms of cardiometabolic disease, which, by the way, is a major risk factor for both AMD and for Alzheimer's. The Bonn conference, I don't have time to go into it, but we can see all of our wonderful colleagues there. Alan and I started this over 10 years ago, where we've had major success in Cambridge University, at Downing College, presenting and working with all the scientists from across the world. And we're moving now for the next conference in 2025 to Boston. So we look forward to that, and we welcome you all to that event. These are my girls. I like this. Research is seeing what everybody else has seen and thinking what nobody else has thought. And we have seen a lot, no pun intended. And we now need to think what nobody else has thought. And we need to empower medical professionals to do the right thing to help their patients. So that's it. This is my team. Wonderful people. This is the current team. I'm putting that up. You can see it flying. All of these individuals are working on new projects, the next generation of science. We're committed to the future of this. And we're very excited about what's coming, particularly around that area of inflammation. So to thank Joanna Cortaril from Portugal, who helped me putting this story together, which I know I went over a little bit. But thank you, Joanna, for your great work, and Karen, who's here as well in the audience, for her work. We need to stay on top of innovation. Everything that I've presented tonight is from published science. It's all available, open access, on the website, and those QR codes. Gaurav Mila Mahagut, thank you very much.
Very good. So, John, if you go and sit in one of the chairs, and then we'll ask the three panellists to come up, please. We have Nigel Davis, consultant ophthalmologist from Guy's and St Thomas's, Dr. Gordon Plant, consultant neurologist from the famous National Hospital for Nervous Diseases and Moorfields, and we've already heard about Riona Mulcahy, from consultant geriatrician and clinical director at the University Hospital Waterford. So maybe we've heard John's story. One question for John. The regulatory authorities are really tough to persuade that any new treatment, especially a supplement, does the trick. Where are you with the regulatory authorities?
It's a great question. I mean, food and food supplements are not considered medications, so they don't fall under that criteria. It's not treated the same.
Right.
So we do have EFSA, which have health claims related, but that's just claims which are miles behind. I think nationally here in the UK, and I see in Ireland as well, they will default to recommendations from consortiums in that regard, but we're miles behind in terms of what the recommendations should be.
Right.
So it's different, you know. I mean, what I'm saying, it's not treated like a medication.
Sure.
I think it should be treated as a food for special medical purpose.
Yeah.
But it's just not used.
Let's get the panels. First, tell us what you actually do. You two work together, Iona, don't you? Just tell us a little bit about where you fit in. You're a geriatrician, right?
So I suppose specifically with the REMIND trial was taken in patients who have established Alzheimer's disease. And we showed lots of things at that trial, which was important. One, the patients were delighted and were well able to take food supplements, which was something we weren't sure they would be able to do if they have established Alzheimer's disease. But the feedback from patients and their collateral, and all collaterals were taken from an independent third party, really showed that there was such significant improvements in memory, mood and behaviour, because Alzheimer's disease is a multi-domain syndrome. It's more than forgetfulness, it also affects your ability to do your everyday activities and your mood. So there was this generalised improvement in a feeling of well-being. I think there are such exciting developments now about earlier diagnosis of Alzheimer's disease and mild cognitive impairment using new biomarkers. But critically, if we're diagnosing people earlier in their trajectory, we have to be able to say, well, what can we do to help you? And yes, there's new drugs, but the whole point of a talk like this is that these carotenoids support healthy brain environment.
Right.
Healthy brain environment ultimately will support not prevention, but delay of onset of disease or amelioration of symptoms. So when we give an intervention, we have to be sure there is a positive outcome, and that's where this research came from.
So, Nigel, from the ophthalmological point of view, what are your views about is a huge problem, macular degeneration?
Macular degeneration is a huge problem. My subspecialty interest is the retina, and I spend a vast majority of my working week with patients with retinal problems. And there's no doubt in my mind that recommending the antioxidant multivitamins and the macular pigments as a supplement is a very good thing to do. And it's not so much that we don't recommend them, it's that they're not supported in terms of being a prescribable agent. That's the thing. So we do say to your patients, we recommend that you take these things. Don't smoke, that's very important. Have a very healthy diet if you can, as best you can. Take some omega-3 oils, but also take the macular pigment supplements. If you have beyond a certain stage of macular degeneration, then taking the AREDS formulation or equivalent, I think, is a very good idea. But the patient has to buy it themselves. When you go to the shop to buy that, if you want to buy a 3-month supply, it'll come up to about £90. Now, for a lot of people, that's a lot of money. I try to decompress that a little bit by suggesting that it's just about £1 a day. And people will buy a newspaper for £1 a day or a cup of coffee and costed coffee for increasing amounts of pounds every day. So I think you can make it appear more affordable, but it's not a prescribable thing at the moment. But we definitely recommend taking it.
It's about £4 for a newspaper these days.
I was just going to say the cost of going blind is significantly more, and I totally respect and I welcome your support of this. But we actually did cost-benefit analysis modelling in Ireland using modelling data from AREDS and from all the MACU prime work that we had. And we demonstrated that we could save the healthcare system millions and millions if they were to provide it for free to patients with a certain kind of, even at early stage macular degeneration. And one of the important pieces here to point to, however, I have to say it, is quality. A casual, I love the way you talk about prescribing, because I totally agree with you. A casual recommendation around nutrition allows the poor patient into a scenario where they're buying supplements that have no active ingredients. Now, that's the most costly supplement of the lot. So there needs to be, you use the word regulation.
Yeah. There's a baffling array of supplements in there. You walk in there and there are thousands and thousands of them out there. I'm going to come on to you, Gordon, in a minute, but Nigel, prevention is better than cure.
Absolutely.
So what are we doing wrong? How could we prevent getting macular problems in the first place? Are we spending too much time with our iPhones? Are we not wearing sunglasses enough?
I don't think so. I tend to recommend that if people are going out, particularly with Caucasian skin, if one's going out into the sunlight to the point where you would put sun cream on, then you should protect your eyes as well, because you know you're going to get some damage. I think it's my understanding, please correct me if I'm wrong, that it's the overall light exposure through one's life that is the damaging thing. But whether blue light and the lights we have at night time are important is difficult to know, but they must play a part. For millions of years, the Earth has been rotating around and around, and there's been darkness for half the day and light for half the day, and our entire body physiology is built toward that. So our lack of proper light cycle has many effects, not only on the eye, but on the cardiovascular system and other things as well. So maybe the light exposure in the evenings is not such a good idea, but I'll be guided by John what he says to that.
No, it's a fair point. I mean, it's called the blue light hazard ratio.
Yeah.
And there's two ways you can make the retina sick with light. And one is light that has high energy. So sunlight is a prime example of that. So short exposure to excessive sunlight is very, very damaging. But the other way you can cause damage is even at low intensity lights, which what iPads have, is the excessive time we spend on them. So it's like intensity and or time equal the problem. So we have created new environments.
It's scary how much time we spend. I mean, 3 hours a day I spend looking at my screen these days.
Yeah.
Gordon, Alzheimer's disease is a massive problem. And what are your thoughts about preventing it, treating it, and the role of supplements?
I think the evidence is speaking for itself, actually, that the supplements are important. But I do think, I absolutely agree with you, that even more than with macular degeneration, this has to be started early if it's going to have a significant impact. Because if we're just slowing down a process, once we're in the diagnosable, usually diagnosed stages of Alzheimer's, I think they can help. But it's really too late to make a major difference to what's going to happen in the long term. And I think, as you say, we're just living too long for our biology, aren't we?
The new drugs in Alzheimer's that in the last couple of months have been NICE approved?
So I suppose just to comment on those new drugs, and they are very exciting. Certainly the newer drugs are showing benefit on memory and they're showing improvement on function. But there are issues associated with them. So if we take a socioeconomic cost for a start, the drug cost is about £25,000 per year, but the delivery is £90,000 per year when you include MRIs and CSFs and various tests that have to be done. So certainly they are very exciting, and I would correlate them maybe to a little bit like when you're starting oncology, you're starting a drug for stage 4 melanoma. There's huge cost, and I think watch that space, it's very exciting. But to come back to the cost maybe of nutritional supplements and the £1 per day, I think if you put them into context of comparing £1 per day to £90,000 per year with definite improvement, that's really across many things, vision, brain health, and probably many other cardiometabolic features as well. I think we need to maybe lobby government that nutrition should be prescribable or should be reimbursable, because really we do need to go down that route.
And what about the damaging, I'm going to ask the audience to ask some questions just a bit, but what about the damaging nutrition that we're having? John, you showed your ultra-processed food slide, it looked like a hamburger there, but there's a whole load of other ghastly things that we're all eating. Any thoughts in the panel about how do you change people's behaviours when every football match they watch, these things are being advertised and billions is being spent on marketing?
Yeah, I mean, it's remarkable because those ultra-processed foods we know lead to obesity, and we know that obesity itself, body fat, competes for the uptake of nutrition. So the poor eye once again loses out, because if we have excess body fat, all these fat-soluble micronutrients are going into those fats. So it's a very dangerous process. But even like, the point is, even, I made reference tonight about the healthiest person in the room a few times. even that person who we should compliment, we should ask to continue to find ways that we can educate at school level. We're doing work at the moment actually with schools. We're calling it the Lunchbox Project, where we're after being able to successfully add carotenoids to yogurts. So kids are getting carotenoids now from yogurts, because I think we need to get this very early into our system. And I think we have to accept that we live in a world where it's very difficult for the mums and dads to get enough of the micronutrients on the plate for kids to be healthy during their life and then as we age.
Yeah.
It's just a fact.
But do you think you could do what your supplements are doing with a change in diet? I mean, could you replace
Great question.
the supplements just with a change in
Well-
diet, or is that not possible?
It's not possible. I did one experiment where I made smoothie, and I made a smoothie about 6 milligrams of lutein we got into that smoothie. It was disgusting. It cost 3 times that of the supplement, and the response was 4 times less. So now that's kind of unfair, because the benefits of good nutrition have to be over time and cumulatively. But I don't see how we're going to be able to change what's happening with food devolution to protect ourselves against this when you add on the other side of the equation aging, growing population, and environmental and lifestyle stresses. I'm not saying good nutrition is not important. It's the pillar of what we should recommend as doctors and scientists. But we also have to open our eyes to the reality that we've identified that there are micronutrients which are safe, high quality to source if they're the right formula, and that they're having these effects. And this is not just effects demonstrated from Waterford. Projects with the same formula done here in Moorfields in the UK, all over America. And the biggest validation, by the way, and we see it in optometry. Optometrists that have used this successfully with their patients see the benefits in their clinic. So this is what, it's validated the science. And I think it's very exciting, but I think we need to kind of work together. I think Prof. Mulcahy referenced, lobbying and everything that goes with that. And,
The challenge you're up against the food manufacturers, aren't you?
The Taoiseach of Ireland,
Yeah.
the Taoiseach, who's a medical doctor, who's no longer in politics, left, and he said in the Dáil that all food supplements were snake oil.
Yeah, that's
Now,
unhelpful.
That was really unhelpful. And so I think we have to start at the top and work down where we can use the information.
But I also think you're absolutely right that regulation is so important, because otherwise people do not know what they're buying.
I totally
they
agree.
do not know what they're buying.
And this is where...
Patients send me tablets and say, can you tell me what's in these tablets?
Well, we can now. That's where Supplement Certify comes in. I mean,
Okay, hang on. We need to bring the audience in. The lady with the scarf at the back, could we just give her the mic there? Tell us who you are. Speak nice and clearly. It's like BBC question time, isn't it, really?
Hi.
Hope not.
Is this working?
Hope not, yeah.
It's all right.
Good
I
point.
got a loud American voice. Thank you very much. That was fascinating.
Sorry, could you hold
my
the...
name is...
could you
Hold the mic near your mouth. Yeah.
Yeah.
Yes, working.
Hello.
Yeah, hold it close to the mouth there.
Okay, here we go.
That's better.
So anyway, my name is Tatiana Christides, and I'm a senior lecturer in medical sciences at Bart's Medical School, Queen Mary. And my background is I was a consultant in internal medicine. I'm also a nutritionist. So I had the exact same question that's already been asked about foods, but I had another medical question, which is, and I'm sure you know about this, there was the CARROT trial and several other similar trials in the mid-90s, where because of epidemiological evidence of people who ate a lot of fruits and vegetables with high levels of beta-carotene specifically, they had a lower incidence of cancer. So let's give this to people who smoke, who are at risk for lung cancer. And let's see if their lung cancer rates go down. And of course, their lung cancer rates went up. And the study was stopped prematurely. And there's actually, I believe, caution on certain supplements of beta-carotene, I think.
Absolutely.
Where if you smoke, you're not supposed to use them. And I saw your data, and I just didn't know, has that been done in people who smoke? Because of course, obviously, smoking is also a risk factor for macular degeneration. And what's the safety signal with these other carotenoids and risk of lung cancer or other cancers?
Yeah, thank you for your excellent question. And it's exactly why there's been so much success with just using the 3 carotenoids in MacuPrime, because I showed you the purity slide. When you look at some of the supplements that are out there, they have high amounts of beta-carotene. And that, as you say rightly, even ARIDS showed, the ARIDS study itself showed that using beta-carotene increased risk of lung cancer in cigarette smokers. The safety data related to these 3 macular pigments is exquisite, initially in animal models and then as we move into human models. I now have 15 years data from clinical pathology assessments across patient populations, and it is perfectly safe.
Including smokers?
Including cigarette smokers, absolutely.
There's a question from the lady with the purple dress. Thank you. And then the gentleman in the front there.
My name's Patricia Hitchcock. I'm a lawyer with a genetic risk for both these conditions. I had 2 questions, both very short. Is it sensible to think about prophylactic use in anybody of any age? Or is there a too young, too old cutoff? And is there any purpose in short-term use of supplements, or does it have to be a lifelong usage?
Great question.
So absolutely great question. I think, as John has just alluded to, there is fantastic safety data with xanthophyll carotenoids, which are these specific carotenoids are. And there is no doubt that we would like to do so much more studies on normal people before they develop any of these conditions. But there has already been some work done in the CREST trial, which John alluded to, which is where you can improve cognition and improve vision in people who actually don't yet have any signs of disease. So there is no doubt that taking these conditions can enhance your brain health and enhance your overall health. But to answer the question, frankly, do we have large-scale studies to show that? No, but we have biologically plausible reasons as to why it would make sense to take these earlier. And maybe just briefly to talk about a study that I did recently where I run a mini med school for students who are 16 and 17 years old. And we brought these kids and checked their skin carotenoids and had a brief food questionnaire with them. And it was remarkable to see the people who said, well, no, I hate vegetables and I never eat them and whatever. And it did correlate with low carotenoid levels and vice versa. And you were able to very quickly pick out the people who were eating poor vegetables at that age. So we need to enhance brain and body health at all ages, and I believe you can't start early enough.
Yeah.
And it
I just
was
want to
£90 a month was mentioned. Is that right? How much that would cost for this, for the carotenoid?
So the current formulation is about £1 a day. Is about £1 a day is what.
Yeah.
Is
I
what
just
it
want
is.
to add one thing for your question. Should people take it in the absence of any disease? But just with reference to macular degeneration, the ARIDS study showed that patients who took this contained vitamin C, vitamin E, zinc, copper, and the beta-carotene, and then later the macular pigments. There was no known benefit in terms of developing any macular degeneration, but I think in ladies there was an increased risk of osteoporosis and some cardiovascular events because of the vitamin C and the vitamin E. So that we don't recommend that people take the full high-dose antioxidant vitamin supplement in the absence of any problem. I think the carotenoids are perfectly safe, but not the high dose of the other vitamins. Hope that makes sense.
Good point. Sir, tell us who you are. Tell us who you are.
Jerry Cockaday, one-time diabetologist. Could you say a little, apart from whether carrots are any good, could you please say a little about the contrast sensitivity test and its relation to the distortion and visual acuity deteriorations of AMD?
Yeah, absolutely. So we did a major study working with patients with age-related macular degeneration, and we profiled all their visual functions. And as I said in the presentation, contrast sensitivity significantly correlates with the stage of disease. And it also correlates with how the patient feels about their vision. So if patients that get improvements, it's the measure that we see to win first. And as patients' retinas get sick, it's the measure that we see to deteriorate first. So it's much more sensitive, in other words. And it makes sense to me. Just look around this room. Do you see anything 100% contrast, black on white? It's not how our retinas or our brain functions to experience that visual. So we're not measuring it sensitive enough, so it's crucially important.
What is the test?
So you can measure contrast sensitivity with multiple tests. It's basically it's a test that distinguishes the foreground from the background, as you know. So you can pick a particular cycle. Well, I'd recommend 6 cycles per degree.
Brief answer here, because we don't get bogged
6
down.
cycles per degree would be the test I would do, and you can use any system to do it. There's not one particular system that I'd advise over the
A
other.
lady with a microphone over there.
Oh, thank you. My name is Francesca Albini. I'm normally a medical journalist, but I'm here as a patient tonight. I was diagnosed with glaucoma and macular degeneration. Am I unlucky, or do they happen often together?
I think Nigel, question for you.
I think they are both very common problems. So a lot of people will have a mixture of macular degeneration and a mixture of glaucoma. There are some genetic elements of glaucoma, and there are genetic elements of macular degeneration, but they don't necessarily cross over. So I don't tend to think that somebody who presents with macular degeneration inevitably has an increased risk of glaucoma and vice versa. But because they are common problems, that's very difficult to disentangle. We tend to think of them as slightly separate things.
You might think whether you would have found out about the AMD if you hadn't developed glaucoma.
Yeah.
That's often the way around it goes. It's so common. You go for some other reason and you've got it. There are weak links with glaucoma and Alzheimer's and AMD, but these are very weak.
Gordon, we mentioned familial cases of AMD and Alzheimer's, and there are some genetic tests now that you can get showing genes. Just tell us a little bit about that.
Well,
and is it helpful to know that you're going to get these problems?
Well, there's 2 different situations. One is a familial form of Alzheimer's.
Yes.
And they tend to be rather different. They tend to present much earlier in life. And then there's a range of things which are risk factors, but there's no kind of cocktail of tests that you can have unless you're in one of those families. These other things are just risk factors.
And then the people I know with that problem, some deteriorate quite quickly, others have a very slow deterioration. Is there any rationale for that, or is it just potluck?
Oh, I think I could answer that. I'd probably know more about Alzheimer's disease than anyone else. It is fascinating. What's your views on that?
Maybe the strong genetic subtypes
yeah.
who are homozygous for ApoE4 and who develop it very young, they tend to have a slightly different amyloid accumulation pathology. They're accumulating amyloid from much earlier on and at a much faster rate. The important thing, though, is with any genetic predisposition, you still have modifiable and reversible risk factors. So I think Livingstone in The Lancet published that about 40% of your Alzheimer's risk is potentially modifiable. And of course, in all of that, he mentioned lots of things like managing hypertension, stop smoking, improve your social isolation, and improve your hearing. So we're quite happy to say to people, spend £5,000 on improving your hearing, which is critical. But yet the advice around nutrition remains very generic. Follow a good diet. But if you have Alzheimer's disease, following a good diet might be having tea and a scone 6 times a day because that's what you want to do. So I think we have to be much more focused and specific in our advice that we give to patients.
And there's quite a genetic element in macular degeneration as well. It involves the inflammation system. There's a part of the immune system called the complement pathway. And there are a group of people who have a genetic defect, which means once their complement pathway has been activated, they're very slow to switch it off. And that's been very clearly associated with ongoing slow inflammatory damage in the retina. And that's called the Y402H genes. And some of the therapies that are being developed to inject try to switch that off, but it hasn't been very successful.
Let's have a last message from each of the panel, a take-home message, one thought for the audience. Should we start with you, Nigel?
One thought.
Yeah,
well,
only allowed
3.
one. Otherwise, the guillotine comes down.
Don't smoke. Good diet. Good exercise. Macular pigment supplement.
Okay, that's 4 thoughts, but we know what you mean. A healthy lifestyle, you could say. Yeah.
Well, if
Gordon.
I would be allowed 2,
Yes, you can have 2.
it
Yeah.
would be concentrate on early diagnosis and also get around this stupid problem about nutritional supplements not being medicine. It's crazy, absolutely crazy.
Rihanna.
I'm on the same way. The modifiable risk factors. So healthy brain aging is so important, but specifically if we have something that will alter your diet, we should be doing it, and we need to lobby and make that very much part of our everyday medical practice.
John, you got the last word.
There's 3 parts of macular pigment jigsaw. It needs to be implemented now.
Right. On that note, there are some drinks outside. I think my wife told me that instead of talking about Alan Howard, I talked about John Howard, and John Howard didn't die aged 91 3 years ago. He's alive and kicking in the front row. It's Alan Howard that started the Cambridge Diet, an amazing man, but actually Julie and John are also fantastic people, and we should thank them for sponsoring this evening. Thank our speakers. John, your enthusiastic delivery, fantastic, lovely slides too, and our panellists as well. So thank you very much, everybody. A round of applause.